With that, we move now to the colon. A 59-year-old man is referred for evaluation because he's been fainting at his job where he operates heavy machinery. He's pale and gaunt, but otherwise his physical examination is remarkable only for 4+ occult blood in the stool. The lab shows a hemoglobin of 5. You know, any experienced clinician will instantly recognize this vignette as a cancer of the right side of the colon. Cancer of the colon is almost invariably an adenocarcinoma. 98% of the time is adeno. They grow into the lumen and they eventually bleed into the lumen. When the cancer is on the left side, the growth and the bleeding give symptoms. Change in bowel habit, constipation, blood the patient can see outside the stool. But when it's on the right side, it's very silent. The right side of the colon has big lumen, it has liquid feces that do not need a lot of room to get by. So we very rarely would see signs of obstruction on the right side. And even the blood that is coming from the tumor, because it mixes with the liquid feces on the right side, become invisible to the patient. So all you have is a steady loss of blood into the lumen of the right side of the colon that eventually shows up as anemia. The patient then is found to be anemic. You look at the stool and do the stool guaiac, it is positive ×4. And then you do a colonoscopy and you see the cancer. You biopsy, you transfuse a patient, and then you do a right hemicolectomy. And the next vignette, though, we see the manifestations when the tumor is on the left side of the colon. 56-year-old man has bloody bowel movements. He now recognizes the fact that there is blood in the stool. The blood coats the outside of the stool. Has been present on and off for several weeks. For the past 2 months, he's been constipated. His stools have become of narrow caliber. So you see the interference with the normal flow of the now solid stool through the narrow opening provided by the tumor, plus the blood that is visible. Endoscopy and biopsies will provide the diagnosis. Most likely, the first physician who sees this patient will do a proctosigmoidoscopic exam. Will do an endoscopy with a short instrument that most physicians have and can use and make the diagnosis that way. But before we do a surgical procedure, a full colonoscopy has to be done because cancers of the rectum, when they show up, may already be multicentric. There may be a cancer number 2 elsewhere in the colon. You don't want to resect the obvious one and leave behind the other one. We now move to vignette number 18. A 77-year-old man has a colonoscopy because of rectal bleeding. A villous adenoma is found in the rectum, and several adenomatous polyps are identified in the sigmoid and descending colon. The question, the issue on this vignette is which polyps are pre-malignant and therefore have to be excised, which ones are not. In descending order of likelihood of becoming cancer, the most likely one to become cancer is familial polyposis. It's virtually 100% that will turn into cancer. So familial polyposis and the variants which include garnets, you need to resect the colon. Villous adenoma comes next. Pretty high incidence of cancer degeneration on villous adenoma, and next to it at roughly 10% likelihood is adenomatous polyps. On the other hand, benign, and therefore you can leave them alone. They include juvenile polyps, Betz-Jeghers disease, inflammatory polyps, and hyperplastic polyps. The next question deals with inflammatory bowel disease. In the US of A, we very rarely see bacterial colitis like we see in many other parts of the world. When we see a patient with protracted diarrhea, blood in the stool, etc. in the US, we think of either Crohn's disease or chronic ulcerative colitis. Let me read you this vignette, which is an example of chronic ulcerative colitis. Crohn's disease, let me add, is not what we call a surgical disease. We cannot cure Crohn's disease with an operation, because Crohn's disease can happen anywhere from the mouth to the anus. We cannot resect all that. So we operate on Crohn's disease only for the complications, for bleeding, for obstruction, for perforation or fistula formation. But on the other hand, we can cure chronic ulcerative colitis because it is typically confined to the colon, which can be, if necessary, removed. So let me read you a vignette. A 42-year-old man has suffered from chronic ulcerative colitis for 20 years. He weighs 90 pounds, has had at least 40 hospital admissions for exacerbations of the disease. Because of a recent relapse, he's been placed on high-dose steroids and Imuran. For the past 12 hours, he's had severe abdominal pain, temperature of 104, and leukocytosis. He looks ill and toxic. His abdomen is tender, particularly in the epigastric area, and he has muscle garden rebound. X-rays show a massively distended transverse colon, and there is gas within the wall of the colon. I'm going to give you the diagnosis and then analyze the vignette with you. This man has chronic ulcerative colitis with a toxic megacolon. But actually what I did with this vignette was to include there all the indications for surgery in chronic ulcerative colitis. As I pointed out, we can cure this disease with an operation, but we are reluctant to do it because that operation always has to remove the rectal mucosa. There is always involvement of the rectal mucosa. If we leave it behind, we haven't cured the operation. And that means the patient has to end up with either an ileostomy or an ileoanal anastomosis, both of which give a lot of problems. So when do we feel that we can operate with a good conscience? Let's read it again. This man has suffered from chronic ulcerative colitis for 20 years. There is a first indication. Once you have the disease and remains active for that length of time, you're going to develop a cancer. You need your colon removed. He weighs 90 pounds, has had 40 hospital admissions. Well, life is now totally, interfered with by the disease. This man cannot do anything because the disease is, commanding all of his attention. He needs the operation. Because of a recent relapse, he's been placed on high-dose steroids and Imuran. Well, that's a cure that's worse than the disease. If he's long-term immunosuppressed, that leads to all kinds of complications. He'd be better off without the colon. And the last half of the vignette, it's the complication called toxic megacolon, which needs emergency surgical resection. All right, we move now to vignette number 20. A 27-year-old man is recovering from an appendectomy for gangrenous acute appendicitis with perforation and a periappendicular abscess. He has been receiving clindamycin and tobramycin for 7 days. 8 hours ago, he developed watery diarrhea, crampy abdominal pain, fever, and leukocytosis. Anytime you read a question on the exam, somebody's being on antibiotics, now they have bad diarrhea, you think immediately of Clostridium difficile. Historically, the first antibiotic to be linked to it was clindamycin. And so clindamycin is a very good clue here. Although we now know that any antibiotic can do it. And in fact, the cephalosporins are the most likely cause at the present time. But when you see this clinical picture that I've described, you know this is Clostridium difficile. You make the diagnosis by identifying the toxin in the stool. Cultures take too long. Proctosigmoidoscopic exam may or may not have the typical findings. So you rely on toxin in the stool. Then you have to stop the offending antibiotic. You should not use anti-diarrhea medication. And then to kill the Clostridium difficile, the drug of choice is metronidazole by mouth. You want that to be in the lumen. And for some reason you cannot use that, your second choice would be vancomycin. Let me add a bit about this disease. This disease has been increasing in incidence and virulence. And we're now beginning to recognize cases where failure of medical management require emergency colectomy. And we recognize that because if a patient has a white count above 50,000 and serum lactate above 5 millimoles per liter, they're going to need an emergency colectomy. This is a new twist on this disease. With that, then, we're going to move to anorectal disease. But before we do it, let me show you a number of pictures that we have that are related to the topics we just talked about. Here is a picture of a cancer of the colon with a pretty classical apple core lesion. And here are polyps in the colon. Here is a picture of chronic ulcerative colitis. So a picture like this might come with the vignette that describes the patient with CUC. We next have a picture of hemorrhoids as they look in an endoscopy, and this will be a lead to the next chapter to be reviewed. But before we get to that, I have a couple of more pictures about the bowel. Here is Crohn's disease. And here is another picture of inflammatory bowel disease. We're now going to review vignettes that deal with anorectal disease. Let me have a very important introductory comment. If the question describes the patient's symptoms, but there has been no physical examination done, even though those symptoms may be very suggestive already of what the diagnosis is, the next thing you're always going to do is examine the area. In other words, we do not prescribe medication for anorectal disease on the basis of a history alone. You have to look, you have to do the rectal exam, you have to do the proctosigmoidoscopic exam. So if that wasn't done already in the vignette, it's always the next thing to do. All right, with that introduction, let's begin. A 60-year-old man known to have hemorrhoids reports bright red blood in the toilet paper after evacuation. Let me read the next. A 60-year-old man known to have hemorrhoids complains of anal itching and discomfort, particularly towards the end of the day. He has mild perianal pain when sitting down, finds himself sitting sideways to avoid the discomfort. Here is a rule on hemorrhoids. Internal hemorrhoids typically bleed but do not hurt. External hemorrhoids typically hurt but do not bleed. And I might add, if internal hemorrhoids are big enough to be prolapsed, you can have both, the bleeding and the discomfort. So you know then from this description that the first of these two vignettes is probably internal hemorrhoids and the second one is external, or big internal ones that are prolapsing. But you would not prescribe any kind of management yet in the way of therapy because neither of these vignettes has had the exam. So what is the correct answer for both of these vignettes? Do an anoscopy, do digital rectal exam, do a proctosigmoidoscopic exam, do the diagnostic tests first. You don't want to overlook the cancer of the rectum that you might think it's in fact hemorrhoidal disease. Now, once you've done the exam, the management of internal hemorrhoids takes advantage of the fact that they have no innervation for pain. So an office procedure can be done where we do rubber band ligation. We essentially strangle that hemorrhoid with a special rubber band and it will fall off. If on the other hand the external hemorrhoids or big internal ones that are prolapsing require management, it would have to be a surgical intervention to remove them. We move now to vignette 23. A 23-year-old woman describes exquisite pain with defecation and blood streaks on the outside of the stools. Because of the pain, she avoids having bowel movements, and when she finally does, the stools are hard and even more painful. Physical examination cannot be done, as she refuses to allow anyone to even draw apart her buttocks to look at the anus for fear of precipitating the pain. This is a very good description of anal fissure. It happens to young women, it is very painful, it has little streaks of blood. This is an anal fissure. But realize that as you read this, physical examination hasn't been done. In fact, the patient doesn't let you do it. What is the first thing you need to do? Physical examination. Although obviously in this case, under anesthesia. And then you'll see the fissure, and then here comes the management after the diagnosis is being established. We believe that all of us, when we have a bowel movement, when we wipe the rear end, we do little damage to the mucosa. That trauma creates little fissures in mucosa. But because the blood supply is so abundant in the anorectal area, that heals very fast on all of us. These young ladies who suffer from the disease that we have described are said to have a very tight rectal sphincter. It cuts off the blood supply. So the little minor trauma leads to a fissure that doesn't heal. And therefore the therapy is directed at relaxing that sphincter. Nitroglycerin suppositories, injections of botulinum toxin, or if surgery is required, what is called a lateral internal sphincterotomy. Let's move now to vignette 24. A 28-year-old man is brought to the office by his mother. Beginning 4 months ago, he's had 3 operations done elsewhere for a perianal fistula. But after each one, the area has not healed, and in fact, the surgical wounds have become bigger. He now has multiple unhealing ulcers, fissures, and fistulas all around the anus with purulent discharge. There are no palpable masses. This is a pretty classical description of Crohn's disease affecting the anorectal area. Even the way the vignette begins. Because most people who are 28 years old are no longer taken to the doctor by their mother. When you read that, you realize this man has had a chronic, debilitating disease that has made him dependent on his family for support. And in fact, we expect any kind of surgery in the anorectal area to heal very quickly, given the excellent blood supply. When we read that it doesn't heal, that immediately suggests inflammatory disease, Crohn's disease. He needs a good examination of the area, including then biopsies. The pathologist will report Crohn's disease, and medical management then will be used. We're now on vignette number 25. A 44-year-old man shows up in the ER at 11 p.m. with exquisite perianal pain. He cannot sit down, reports that bowel movements are very painful, and has been having chills and fever. Physical examination shows a hot, tender, red, fluctuant mass between the anus and the ischial tuberosity. This is a pretty common thing, an ischiorectal abscess. Like all abscesses, this one has to be drained. So this man is going to end up in the operating room with a suitable anesthetic, and we can drain the pus. But because this is the anorectal area, we also have to do a proper examination. It would not be kind to the patient to do it now that he's got all that pain. But once he's anesthetized, before we jump to the knife and cut and let the pus out, we do the rectal exam, we do the proctosigmoidoscopic exam. We want to make sure we're not mistaking an infected necrotic cancer for a more benign ischiorectal abscess. And let me add another detail. If the vignette were to say that this man with ischiorectal abscess is a diabetic, severe diabetic, lots of insulin requirements, you better keep that patient in the hospital under very close observation, because in that type of patient, this disease often is the beginning of one of those horrible soft tissue necrotic processes that advances very rapidly and needs a lot of debridement. So this patient would need close observation if he were diabetic. Vignette number 26. A 62-year-old man complains of perianal discomfort and reports that there are fecal streaks soiling his underwear. 4 months ago, he had a perirectal abscess drained surgically. Perirectal abscess is the same as ischiorectal abscess, the thing we read in the previous vignette. Physical examination shows a perianal opening in the skin, and a cord-like tract can be palpated going from the opening toward the inside of the anal canal. Brownish purulent discharge can be expressed from the tract. This is a fistula in ano. A fistula in ano is not a disease that can happen to anybody. It can happen only to people who previously had an ischiorectal abscess drain. And what may happen, doesn't happen every time, but what may happen is epithelium migrating from the skin, epithelium migrates out from the anal canal where that pus used to be and was drained, and if the epithelium meets, you now have a tract that goes from the anal canal to the outside. That is what this individual has, and you can feed it with your finger, and you can see the little fecal material coming out when you express it. And this can be taken care of with a little operation called a fistulotomy. And we move now to the last of the vignettes dealing with the anorectal area. A 55-year-old HIV positive man has a fungating mass growing out of the anus and rock-hard and large lymph nodes in both groins. He has lost a lot of weight and looks emaciated and ill. This is a very good description of squamous cell carcinoma of the anus. Not adenocarcinoma of the rectum that we already talked about. Adenocarcinoma of the rectum, the patient cannot feel that, that's inside. Squamous cell carcinoma, the patient may be able to feel the fungating mass, and furthermore, it metastasizes to groin nodes, which this man has on the physical exam. And it's seen frequently on people that are HIV positive. So we have all of the characteristics here. Obviously, the first thing you need is a proper examination of the area. Eventually, the biopsies, it will confirm it is a squamous cell carcinoma of the anus. And the treatment invariably begins with chemoradiation. This mode of therapy was developed by a gentleman by the way of Nigro. Sometimes is referred to by his name, the Nigro protocol. So Nigro protocol, chemoradiation as a first step. Typically that is followed by surgery after we have shrunk the tumor with radiation and the chemo. So this is the end of the anorectal vignettes.